Okay. So the objective of the study was to determine whether lower urinary tract reconstruction in meningomyelocele patients actually improves the health-related quality of life of these patients. There are many well-established surgical approaches to dealing with the incontinent meningomyelocele patient, and these all have fairly good reported success rates as well as acceptable complication and revision rates. Reconstruction, however, it's a major undertaking. It requires specialized surgical expertise, significant operative time, prolonged hospitalization, long-term follow-up, and also a very motivated patient and family. For the most part, this reconstruction is done for some medical indications, including upper tract deterioration, skin breakdown, or improved institutional care. But also in a lot of situations, it's undertaken because it's felt that it improves the quality of life of these patients. However, there's actually scant data to support this assumption. In fact, on a Medline search done from 1966, running to present, looking for all papers relating to quality of life and surgery for urologic diseases in the pediatric population, only 184 citations were retrieved. Of these, 139 did not apply any sort of quantitative measure of the quality of life. In 10 papers, a non-validated quality of life measure was used, and in only 4 of the 184 papers was a validated quality of life measure actually used. Looking at those 4 papers, 2 authors applied a validated measure to survey children who had renal failure. One author used a generic quality of life measure to look at kids with meningomyelocele, and one author looked at quality of life in a small group of coegal extras patients using a pediatric specific measure. The bottom line is that evidence supporting lower urinary tract reconstruction to improve quality of life in meningomyelocele patients is actually quite lacking. Hence our study. After obtaining ethics approval and funding, a retrospective cohort designed study was carried out. Mail-out, mail-back survey was used. 36 consecutive meningomyelocele patients were recruited who underwent lower urinary tract reconstruction. All of them had intestinal augmentation cystoplasty. About 89% had a metrophenol diversion created. About half had some sort of bladder neck surgery, be it a birch, a swing, or a complete bladder neck closure, and about a third had a continence cystectomy created. Controls were recruited from the meningomyelocele clinic database, and they were matched 2-to-1 with the case patients. They were matched for age, level of lesion, shunt status, ambulatory status, as well as parental marital status, which was used as a proxy for socioeconomic status. The survey instrument used was one that was developed by Parkin et al., and it's an age and disease-specific discriminative measure of quality of life. It's been developed and validated. It's actually 2 separate questionnaires, one used for children 5 to 12 years old that's filled out by the parents, and a second one for adolescents 13 to 20 years old, which is filled out by the patients themselves. And both these surveys have been validated. The survey itself, it's a 44-plus item questionnaire that looks at these 10 domains of quality of life. In addition to assessing quality of life, an attempt was made to assess continence, and for this, a 13-item self-assessment scale was used, as well as a nurse review and a chart review. And acceptable continence was defined as no need for pads or diapers for a period of at least 3 hours between clean intermittent catheterizations. This was the questionnaire we used to assess continence. And our sample sizes were determined in order to detect a 15% difference in the mean quality of life between the 2 groups at 80% power with 5% two-tailed significant levels. Based on these calculations, we needed 12 cases for the child version and 24 controls, and for the adolescent version of the study or of the survey, we needed 20 cases and 40 controls. Overall, our response rate was pretty good, 86%. Unfortunately, we didn't quite meet our sample size as determined by the calculation. However, age, parental marital status, ambulatory status, lesion level, and shunt status were all perfectly matched between the 2 groups. And what we found was that there was no difference in health-related quality of life between the 2 groups, perhaps because of or despite the fact that there were no significant case control differences in the self-reported continence. So based on this, we concluded that the reconstructed cases have the same health-related quality of life as controls. There are many possible interpretations of this. First off is that surgery does not actually improve quality of life at all. It's also possible that surgery improves quality of life, but only up to the level of controls. Also possible that surgery improves quality of life, but only in a small subset of patients, and because of our sample sizes being so small, we weren't able to detect that population. Finally, it's possible that the reconstruction improves the quality of life of the caregivers, and this survey was not set up to assess for that. What we do know, or what we can say, I think, is that the impact of pediatric urologic surgery on quality of life needs further study, and other disease-specific measures of quality of life need to be developed to help us assess interventions for other common urologic problems.